Hello, everyone, from wherever in the world you are, whatever time of day you're joining us. My name is Kevin McAvey. I'm a managing director at Manat Health, and health data is my life and has been for going on 2 decades now. It's my pleasure to be here with on behalf of Robert Wood Johnson Foundation and Academy Health to talk about the terrific program that is Health Data for Action and its amazing results that it's delivered for our field. Data-backed evidence is a powerful tool for helping researchers, community advocates, policymakers, and others uncover health challenges, better target their limited resources and use, and measure progress toward ensuring everyone has a fair and just opportunity to achieve their best health. Yet for far too long, many researchers across our country have had limited access to rich data, a cornerstone of producing timely and objective research. The Health Data for Action program, HD4A, has provided novel and innovative support to democratize data by facilitating the pairing of owners of highly valuable, rich data sources with researchers to generate actionable insights to create fairer, more effective health solutions that work for everyone. Today, I'm here with two of the leads on one of the Health Data for Action projects using transparency and coverage data to understand healthcare price variation. There's a lot under there, and I'm so pleased to have Dr. Chris Whaley, and I'm here with Todd Gottula from Clarify Health. Chris Whaley, Dr. Whaley, is an associate professor in the Department of Health Services at the Brown University School of Public Health. Also associate director, Brown University Center for Advancing Health Policy Through Research, formerly an economist at the RAND Corporation. You've probably, wherever you've seen, I think, a price provider price variation graph. I'll bet Chris played some sort of a role in that, whether it's the New York Times, Wall Street Journal, Forbes, CNN. You're on the governing board of the Healthcare Cost Institute, editorial boards of lots of, I'm not going to go through all this. I'm really happy that you're here. And Todd is president of Clarify Health, where he's responsible for teams that lead product vision, innovation, design, development, implementation, and customer success, really making Clarify Health the data powerhouse that it is. Prior to founding Clarify, Todd was executive vice president and CTO at Advent Software, where he led development from ideation through revenue generation, serving as a bridge between business and engineering. Thank you both for taking the time to talk about your work.
Thank you for having us.
Yeah, of course. So I would ordinarily ask, like, Chris, why did you get interested in this topic and that drove you to this project? But maybe I think that you were probably born interested in this topic. But talk to me about this specific investigation in particular, and what makes it different, or how does it kind of push the field?
Yeah, so first off, thanks for hosting this webinar, and also want to acknowledge the Robert Wood Johnson Foundation. I think the Health Data for Action program is really an ideal situation and program that really does a fantastic job of pairing a lot of industry-focused data with researchers, and kind of the marrying of the two, I think, is really, really productive. So as you highlighted, I've done a lot of work on healthcare price variation over the past several years. And one of the things that we've really learned from that work is that there's just a ton of crazy variation in healthcare that isn't really tied to anything that we think would matter. So quality, access to care, all those types of things seem to explain actually a pretty small portion of just the large variation that we see in healthcare prices in the United States. And as we've been doing this research, we've come up with lots of, I think, good findings. But in some sense, we really don't have it's acknowledged how little we know about healthcare prices in the United States. And I think one of the key missing features, if you will, which is an elephant in the room and really important thing to look at, is just what's the role of insurers. And so when we have done lots of work in the past for a variety of reasons, it's really difficult to both name insurers as well as, in many cases, providers. And so we can say that, look, we kind of know that there's lots of variation in healthcare prices, but we can't really say why. And we can't really say, is this something that's being driven by insurers, or is this something that's just in some sense a fact of life within healthcare?
And Chris, could you just give me like a real world example for folks who might not be kind of thinking about this big picture? Can you give me an example of like how price variation can plays into our purchasing decisions?
Yeah, so we know that a hospital down the street or across town might have prices that are twice as much as another hospital in the same market, even though quality, et cetera, is exactly the same. And I think the other really important topic is we often know that a surgery or a MRI or even a lab test performed in a non-hospital setting is half or in many cases even less expensive than the exact same procedure delivered in a hospital-based setting, even though every study has shown that quality is exactly the same or even better in non-hospital settings.
Really helpful. And so you've been thinking about this and actually doing like really innovative work, presenting to Congress regularly on provider price variation in given markets, even controlling for quality. Like for this project, like how did you look at that in a new way?
Yeah. So whenever we've done these studies, we've kind of had to use the data that we can get access to. And so that's, we get data from one insurer, one state all-payer claims database, but we don't really have the full sample of across data sources and really across the United States. And so that I think really limits what we know about, or at least have known about, healthcare price variation. And so a key advantage of the transparency coverage data, which we've accessed through the Clarify platform, is that we can actually get the full scope of prices from across the country. And so the way to think of the TIC data or the Clarify data is essentially the entire universe of everything you'd want to know about healthcare prices in the United States. And so if we have that database, then we can take what we've done initially using pretty selected samples and actually say, is this representative? Do we, what we think we know about healthcare prices actually true? And then because we can actually identify in the Clarify data individual providers as well as insurers, we can actually say, okay, how much of this is due to something that's unique to insurers, or how much is this due to the fact that some providers just have much higher prices than other providers across the board?
So like I want to dig into the data next and really talk about the difference between some of like the raw transparency and coverage files and Todd, like what you and Clarify provide. But first, maybe a bit of a basic question. Like I'm a consumer, my insurance company is going to cover a whole bunch of like whatever I need for healthcare. Like why should I care about provider price variation?
Well, so if you're like many consumers, you probably have a high deductible plan. And so that's going to impact how much you pay. And you also pay co-insurance and co-pays. And I think that there's, maybe the way I think of using price transparency, at least on the kind of more consumer side, if you will, is that there's, direct action by, say, patients and saying, okay, I know that one provider is cheaper than another provider to, say, get my lab test or my colonoscopy or what have you. And so I'm going to go to the cheaper provider. A lot of studies that have looked at that type of mechanism or that type of action have shown that patients actually aren't that greatest shoppers for healthcare. But where I think that transparency can actually be much more impactful is the level up from patients. So if you're say an employer that's designing networks or monitoring prices that are negotiated on your behalf, now that you have access to this huge trove of price transparency data, you can actually go upstream of the patient and make sure that when the patient is selecting a provider, that their options are the high quality and lower price providers.
Yeah, I have an analogy, a rough analogy for this. If you bear with me, it's sort of think about buying your groceries on a weekly or monthly basis, and imagine a world where you set aside a portion of your income that you paid to your employer, and that was your fixed base for you to go to the grocery store. And then you walked into the grocery store and nothing had prices. You just put what you thought you needed into the bag, and then you checked out. And at the end of your checkout process, you would get a bill or not get a bill based on what the underlying prices of the goods are that you put in your shopping cart. And you had no control because you didn't know what the individual unit prices were of any of the products you put in your basket. And you have no ability to negotiate that. And so then at the end of that process, either you or your employer decides to split the overage. That's the world of healthcare today, or at least it was before the price transparency regulations to start illuminating what the prices are. Now, I don't think we're going to move to a world anytime soon where an individual consumer is going to be able to respond to the individual unit prices. But as Dr. Whaley just said, getting our employers able to understand what these rates are and how they're being subject to them, and therefore how their employees are being subject to them, that's the absolute frontier we're at right now, and what we need to start enabling more and more of, because that's where influence can be exerted. and therefore fairness can be put into the marketplace on behalf of all of us who are ultimately consuming these healthcare services.
And is that where you're seeing interest in like the tech data that you were stewarding, like from purchasers?
Well, so it's on two sides. One is absolutely on the purchaser side, because ultimately that is the most influential consumer or aggregate buyer of healthcare services. And then the other is on the health system or the provider side, right? Everybody wants to make sure that they're being paid fairly for the work that they're doing, right? We talk about prices, and yes, it's prices, but it's ultimately representative of the income that either the facilities or the care providers are receiving for the services they're rendering. And we need to make sure that there's fairness, right? Where people are actually, providers of services are being paid fairly, including for the quality of the work that they're delivering. So it's not just about price ratcheting, like let's make sure that everybody's getting paid the same and continue to increase those prices, because that's not good for anybody. Let's make sure that those that are actually performing appropriate services and utilizing the appropriate amount of services to deliver somebody to a positive outcome are the ones getting the proportionate or disproportionate amount of the income available.
So you've convinced me, like understanding provider price variation, really important. How, and you mentioned, Todd, like over the course of the past 5 years, like that pricing information has become more transparent. The hospital transparency files have come out, the transparency and coverage files from insurers. How does clarify? Can I just go and download that? And is that like easy to use, or like how does clarify play a role in that?
Well, it's a great question. Thank you for asking. And so, picking back up on this analogy of the grocery store, think about if you wanted to understand the price of certain consumer goods across every grocery store in the United States. There's not an aggregate database for that. That's the same when it comes to what health systems are effectively getting paid or charging for services. The same thing for provider groups. It's very, very local where that information resides. And so what the price transparency regulation put in place is that people had to publish this information. But what they didn't do in the regulation is say where they had to publish it, the format in which they had to publish it, and the frequency with which they had to release updates. And so what we have are effectively 6,000 different sites, websites, where this information is posted. And it's non-standard URLs. You know, people don't have to put it on the About Me page or the pricing page. They can put it anywhere on their public-facing website. So the work here is a bit of detective work. You got to go find it.
Yeah.
Then you got to go get it.
Yeah.
And then you have to change the format of it, because there was no stipulation. Now, there was in subsequent updates specifically for health plan publication of this data, but originally it was basically you have to put this data up there and this is what it has to contain. And so the work was really crawling the web to go find this information, bringing it into a local repository, and then converting it into a standard format so you can make sense of it.
So, Chris, that's easy, right?
Well, I was really excited about this data, and when it first came out a couple of summers ago, first day, sat down and said, "Okay, I'm going to download and start playing with it." And then, like I'm sure everyone else tried to do the same thing, my computer crashed. I think one of the statistics, I think this actually comes from Clarify, is that across all payers, the size of the transparency and coverage data is actually larger than the entire movie catalog of Netflix, which that's just a crazy amount of data.
Holy.
It's 3 petabytes of data, and that's a snapshot, right? And you do need to understand this data over time. So every time we create an update to this information, we're replicating essentially 3 petabytes of raw data that then needs to be transformed and processed into the ultimate work product that Chris and his team are able to use and make sense of.
And as I understand it, there's also a lot of there's a lot of data in there that might not actually be meaningful information in the real world. So can you talk to me a little bit about what Clarify does to take like this raw oil to make it like so it's in a form that can be used for research?
Yeah, I'll give you a data point. There is a health plan, I won't name them, that has released price data for a specific provider group. It's an orthopedic group. And for the same service code, there are 1,000 potential prices. So 1,000 prices for one service code for one tax identification number, which is how these prices are basically tagged, which would represent a group of physicians performing a set of services. And the variations are all related to specific nuances of healthcare products, right? Easiest would be a PPO product versus, others. Um, there's other variation in there as well. And so what this is called is the zombie rate problem, where the publishers of this data basically said, look, I guess I won't necessarily call it nefarious, but they certainly said, look, we're going to publish everything we possibly can, because then we'll never be told that we didn't make.
Tell me I'm not complying. I dare you.
Exactly, right? It's guaranteed compliance, but it also increases the complexity of working with the data. So there is a refinement process that we go through to basically pull out what are the zombie rates. And you can do this through a couple of means. One, you can look at duplicate prices and say, well, look, you don't need those duplicates. The other, and the very important activity that we're in a privileged position to be able to do, is you can crosswalk it into historical claims data and be able to say, what are the actual used rates by evidence because somebody's billed this rate. That's actually probably the most important thing that we do, is filtering out the rates that might be published but are actually not being used by any service providers in a billing setting. And that gives us the true in-use amounts for all the service codes that become therefore very valuable for the studies. For example, the one that's on here.
To get nerdy for a second, and for selfish purposes, let's say you find rates where services are being utilized in practice, but the rates aren't aligning up. Is that a kind of a common occurrence, and how do you kind of explain the difference?
Yeah, so it's a great question. So at Clarify, again, I mentioned we're in a privileged position to have a very large repository of de-identified historical claims data spanning the majority of the healthcare that's been rendered in this country. What that data does not have incredible fidelity on is the actual paid amounts. That is considered, for understandable reasons, fairly privileged information. And so while we might have some of that data, what we're really looking for is the billing codes and the treatment and diagnosis information, and who the rendering provider and the billing provider were for those claimed or the billed services, right? Because a claim record is essentially a request to be paid for a service that has been performed. And then there's a corresponding acceptance by the health plan that, yes, indeed, those services were rendered, they were necessary, and therefore we paid it. And so we see some of the payment information, but really what we're relying on is the price transparency data to be able to say, okay, well, this was therefore the likely paid amount because this information was both was both published by a health plan and a provider. So it's that last piece actually where we're doing the crosswalking, because both sides of the effective transaction have to publish their price information. And we can therefore understand, did they both publish the same rate? And that's where we have to do another amount of work, which is making sure that both sides are publishing what appears to be the same amount, so that we can therefore have confidence that, yes, indeed, this was the billing rate for this service code.
From my perspective, cleaning up the zombie rate problem is one of the most critical aspects for using the transparency coverage data. And then I think the other thing that we've really leveraged through Clarify is the linkage to claims data. And one that's helpful for filtering out any of the misleading zombie prices. But the other advantage is we can actually look at, say, providers who perform more of a service. What's their price? And if we're thinking about just kind of looking at kind of directional correlation, as well as if we're thinking about trying to measure things like spending, it's really important to have some measure of quantities, which we can get through the claims data linkage.
Really interesting. And so actually when you were starting to use the data, I don't know about you guys, but when I actually get into a data file, I have lots of questions because some things that I would expect actually to show up aren't there. Did that happen through your project, and what came up and how did you resolve them?
As you might expect with any new data set, but especially something that's totally new, did have a bunch of questions. So especially when we were trying to identify individual, say, physicians or hospitals, how we do that linkage was a bit of a question. And part of this is that a hospital may have 100 different tax IDs, or a physician may have several different billing IDs, and they may vary across insurers. And so making sure that we're definitively mapping, say, a price to a given physician or hospital was something that is a little bit tricky, but we were able to work with the Clarify team to resolve lots of those questions.
I would just echo exactly what Chris just said there, which is that this tax identification to national provider identify crosswalk is one of the biggest challenges. It remains a challenge because it's a fluid situation. New
Mm-hmm.
TINs come up,
Constantly
or
changing. Mm-hmm.
individual physicians will change groups, and so understanding that lineage is a ongoing commitment that we have to make to this data set,
Mm-hmm.
so that it remains usable. And that's also how the provider performance data, where you're looking at utilization, volume, potential total cost of care over a complete episode of care, that's also done at the MPI level. And so, in order to be able to make sure that you're crosswalking the right rates, you've got to have a really high fidelity, high confidence crosswalk between those two data sets.
So we've been talking so far about the data, where it comes from, the information that can be derived from that data, and Chris, as many of your studies and folks look at the Academy Health website, they'll find a whole bunch of them show significant price variation within markets, within payer types, and now I want to talk about impact. Like what does this all like lead to and mean, and who should be interested in this information? You mentioned consumers and purchasers. What about policymakers? Chris, who's using this information?
Yeah. So we've, in addition to, I think, frankly, it's beyond, at least for now, consumers to use the data unless some entrepreneur or innovator takes the data and develops a more consumer focused app on it. We have seen, I think, a fair amount of use by purchasers, and especially self-funded employer groups, union plans, and those who provide health insurance for their workers, in trying to use the data to, again, both monitor prices that are being negotiated on their behalf, as well as make sure that their networks are targeted and steering people towards the high quality, lower price, more efficient providers. There's also been a lot of work, or I think interest from policymakers, especially at the state level. And I think states are particularly interested in a couple of dimensions. So one, just knowing what prices look like in their state, but then also thinking about what's the role of state level regulations, and if prices are being driven by potential anti-competitive behavior, or there's state regulations that could put a curb on some of those behaviors, or at least remedy them. And we've seen interest in several states in actually thinking about those types of policies. The other area where I think there's a lot of state interest is that in many states, the state employee health plan or municipal health plan that provides provides health insurance coverage to public employees is in many cases the largest provider of health insurance in the state. And we've seen lots of interest from states in using the TIC data to make sure that their public employee plans are efficient.
And by that, like looking at actual, like, are other plans getting better rates? Can we press on those rates?
Exactly. Or as we've seen, for example, in the state of Oregon, with their reference-based pricing program, should the state have a policy that, now that they know that there's lots of price variation that isn't clearly explained by differences in outcomes or quality, should there be a kind of maximum amount that the state's willing to pay for healthcare services?
Yeah. And are you seeing that too, Todd, from folks, potential purchasers of the data?
Absolutely. I would echo exactly what Chris just said. With regards to who is the biggest user base for what we do today, it's our providers. So organizations who want to understand how they're being compensated for the work they're doing relative to their market. And again, it goes exactly to something Chris said earlier, which is it's not just looking at the rates, it's putting the rates in the context of the overall journey of care for the individual patient who's receiving those services. So there's an argument to be made that if you're a high performing orthopedic surgeon who has a very low total cost of care, maybe your actual surgical procedure fee should be higher because you deliver better outcomes, lower total utilization of services, and therefore lower total cost of care. And there's a return to function, return to work that's much more rapid. And so there's a lot of strong interest on that side. And then on the other side, it's self-funded employers and then benefits brokers who are then representing sort of smaller purchasers of healthcare services to make sure that they are getting fairly priced plans when they're effectively contracting on behalf of their employees.
And I just one note to add to that too is that it's not just providers saying, I want to know my benchmark across my market. It's in many cases a lot of non-hospital based providers using the data to say, look, our price is a tenth of, say, service at a hospital, and we offer just as efficient care. And so steer your business towards us, and that's our business opportunity.
Yeah, it's a really important point.
But it's not only purchasers that are using that data to choose to seek to negotiate down rates or to kind of streamline networks. It's payers and providers also using that information in a dynamic market to potentially seek price increases. Like, is price transparency, like, which side is going to kind of tip the balance? Like, is this ultimately going to be a good for market competition and cost growth, or is still to be determined?
Yeah, so this is the kind of Danish cement concern, if you will. And I think so if you can imagine a scenario where you're a low price provider and you now see that you are low priced, and go to the insurer and say, look, I'm low priced, give me a better rate. The insurer, if they're doing their job, will say, well, look, the reason you're low price is because fewer people want to go to you and you're just less attractive to our network. And so I think that's a pretty important restraint on prices increasing. And I think the other thing to keep in mind is that many large systems actually had access to this data through claims data and through a variety of consulting services. It kind of knew, I think to a pretty high level, where they fell in terms of prices within in their market. And so I think the real group that hasn't had access to this data are the purchasers and individuals who are actually using data to steer patients to lower price providers, as well as the truly kind of lower price providers in many non-hospital based facilities that are using this data as a way to attract business and steer patients to their businesses.
Yeah, I would just echo exactly what Chris said. I don't think that the data alone isn't necessarily going to fundamentally change the economics of the healthcare. It's what the healthcare industry at large. It's what you do with it.
So, Chris, how'd you use the data, and what any early findings that we can revel in?
Yeah, so we worked with Clarify to get access to their kind of the tick data. The nice thing about the data that we've been using is it's updated as new data comes out, and so we have kind of at least what I think of as the most current look into healthcare prices in the United States at any given point in time. And in terms of using the data, I mean, for us, I mean, we've got a great team of programmers in the data, and and then also had lots of support from the Clarify team. And so it's been, I think, in terms of like other messy data and data problems, actually pretty straightforward and pretty user friendly for us. And so it's been overall great to use. And in terms of initial findings, and so I highlighted some earlier. And so we do find again just across many different services. So whether you look at healthcare services as kind of a basket of goods across the board, or if you look at individual services, so like MRI services, cataract surgery services, emergency medicine services, or even things like say colonoscopies, we find a pretty large variation in prices that again isn't really tied to meaningful things that we think should influence prices, such as quality of care, patient access to care, and those types of things. And then, as I mentioned, also highlighted earlier, where we do find a pretty strong explanation for prices are things around market structure. So whether that's concentrated markets, so hospitals with a dominant market position tend to have higher prices, or physician practices, say, for example, that are directly employed by hospitals or private equity companies tend to have higher prices than independent physicians. And in terms of where you can find these studies, I think most of our published studies are actually on the Health Data for Action website.
Awesome. And actually, that's a question for me. Like, as you're looking at all of this data across the country, you mentioned particular service lines that are prone to have higher rates of provider price variation. Are there particular regions? And just like an ad hoc question, like, what's the greatest price variation in a market that you've seen?
So that's an interesting question. So you think that, okay, if say Wisconsin, for example, is expensive for one service. So we see, for example, Wisconsin has very high physician prices. Then you think, well, it's just an expensive place to operate healthcare in the state of Wisconsin, and so it should just be expensive across the board. But if we look at other services, Wisconsin isn't that expensive. And so that's, I think, some of the interesting thing about healthcare is that there's really not any rhyme or reason for why prices vary from one market to another. And we see that in some markets they're expensive for one thing, but not for the other, and vice versa.
What lessons learned did you take from this project, and what advice would you have for other researchers out there looking to kind of make use of a similar model?
As I started at the very beginning, I think Health Data for Action is a really unique and fantastic program to pair what's being done on the, in many cases, the industry side and a lot of the innovative data sets that are coming out of industry with researchers who have academic questions around these types of data. And it's really a nice blend of the two worlds. And for kind of us, this is, we view the transparency coverage data, which we wouldn't have been able to use without a lot of the steps and work that Clarify has put into it, as a huge step forward for what we know about the healthcare system. And 200 million people get health insurance through a private insurer. And before the transparency coverage data, we had very little insight into the key economic factor that allocates resources and is the most important thing about any economy, and that's prices. And now with the transparency coverage data, we know a lot about prices. And I think that the next step is just unpacking all of this data.
Well, Chris, I want to thank you for helping to ask and seek answers to some of our nation's most pressing healthcare system questions. And Todd, for helping to contribute to the data and information that goes to answer those questions. And both of you for taking the time today to participate in this conversation. It's so good to see both of you.